Hello and welcome to this learning module. In today's session, we're going to chat about the topics of trauma and abuse and neglect in the geriatric population. This video is designed to supplement your readings and coursework that's assigned by your instructor. Trauma assessment in the geriatric population is often complicated by pre-existing medical conditions, polypharmacy, and physiologic changes that can mask the true severity of their injuries. Due to age-related changes in the body, even low-impact trauma, like a ground-level fall, can result in severe injuries like hip fractures and intracranial bleeding. A geriatric patient's baseline vital signs may also differ from those of a younger adult. For example, a resting heart rate might be lower due to medications like beta blockers, and their normal blood pressure reading might indicate a state of shock in a hypertensive individual. A crucial aspect of the geriatric trauma assessment involves identifying all potential injuries beyond just the obvious ones. The initial presentation might be deceiving, as older adults have a diminished pain perception or may be unable to clearly communicate their symptoms due to cognitive impairment. We will use the same patient assessment approach that we've reinforced throughout this course. Complete a scene size-up. Use the primary assessment to find and treat any life-threatening injuries or illnesses. Obtain a thorough medical history. Obtain a good set of baseline vital signs. Complete a focused or detailed secondary assessment as needed. And reassess our patient every 5 minutes if unstable or up to every 15 minutes if stable. Geriatric trauma victims experience a reduced ability to compensate for injuries due to pre-existing physiological changes associated with aging. This leads to lower physiological reserves across multiple organ systems. These changes mean older adults have less bandwidth to cope with the stress of trauma, resulting in clinical presentation that can be subtle even when the injuries are severe. For example, an older adult may have a heart that cannot beat faster to compensate for blood loss, blood vessels that cannot constrict due to atherosclerosis, and or lungs that cannot exchange oxygen as effectively as they used to. Additional circulatory system changes leave the geriatric patient's body unable to maintain normal vital signs during hemorrhage, and their blood pressure drops sooner than it would in a younger adult. Factors including osteoporosis, decline in muscle mass and strength, impaired balance, slower reflexes, and vision problems can all increase the likelihood of a fall. When a fall does happen, weakened bones mean that even low-impact events may result in serious fractures, especially hip fractures, that are associated with long-term disability and increased mortality. Furthermore, comorbidities like cardiovascular disease or diabetes, polypharmacy, and a diminished physiologic reserve complicate the body's ability to heal and recover. This can lead to a higher risk of additional complications like infection, organ failure, and a reduced quality of life for the patient. The fact that the patient may be bedridden for an extended period may also prevent them from being able to live independently. After age 40, most adults begin to experience some spinal degeneration. As this happens, the intervertebral discs become dehydrated and become less rubbery and soft. This leads to disc shrinkage and a loss of disc height. As we age, our spine stiffens due to the shrinkage of disc spaces and because the vertebrae become more brittle. Spinal compression fractures are more likely to happen. Elderly patients are also at increased risk of subdural hematoma. As the brain naturally shrinks with age, the spaces within the skull increase. This stretches and weakens the tiny veins that connect the brain surface to the dura mater. Even with a minor head injury, these fragile veins are more prone to tearing and bleeding. The bleeding slowly accumulates in the enlarged subdural space over days to weeks, forming a chronic subdural hematoma that begins to exert pressure on the brain tissue. Additionally, many older adults take anticoagulant or antiplatelet medications like aspirin or Coumadin to manage their other health conditions. This hinders the blood's ability to clot and significantly increases the risk of severe or expanding bleeding after trauma. Elderly individuals are more susceptible to both hypothermia and hyperthermia. This happens due to age-related endocrine system changes that impair the body's ability to regulate temperature. The body's ability to sense temperature changes is also blunted, leading to a reduced awareness of environmental risks. Key physiological factors include a decline in sweat gland efficiency and reduced skin blood flow, which both hinder heat dissipation in hot conditions. In cold conditions, decreased subcutaneous fat insulation, slower metabolism, and decreased muscle mass and shivering responses can compromise their body's ability to generate and retain heat. These vulnerabilities are often compounded by chronic health conditions, including cardiovascular disease and diabetes. Also, certain medications, including diuretics, beta blockers, and antihypertensives, can interfere with normal thermoregulatory responses, further compromising their thermoregulatory ability. The Centers for Disease Control and Prevention defines elder abuse as an intentional act or failure to act that causes or creates a risk of harm to an older adult. Elder abuse is an active form of mistreatment and is considered a crime. Elder neglect is the refusal or failure by a caregiver to provide a dependent elder with necessities such as food, shelter, healthcare, or protection. Neglect involves a lack of action to fulfill caretaking obligations and can be intentional or unintentional. The United States Department of Justice estimates that over 10% of adults aged 65 and older experience some form of elder abuse each year. We believe that elder abuse and neglect are underreported for several reasons. Abusers are often caregivers or family members that the victim depends on for care, so they fear retaliation, abandonment, or being placed in a nursing home or similar institution. Older adults with dementia, memory loss, or other cognitive issues may not be able to articulate what's happening to them, or they may not realize that they are being abused. Abusers may also use threats, manipulation, or isolation to keep their abuse from being found. Neglect is unique in that it can be intentional or unintentional. This category generally represents a failure of the caregiver to fulfill obligations to the older adult. Forms of neglect include withholding nutrition, water, and appropriate clothing, failing to administer or refill medications, and providing inadequate assistive devices such as hearing aids, glasses, or walkers. A neglected patient may present as being underweight or dehydrated, having poor personal hygiene, wearing dirty clothing, and having long toenails or fingernails. Neglect can also lead to complications from poorly controlled medical conditions. Elder self-neglect is the inability or unwillingness of a vulnerable older adult to provide for their own basic needs. Causes of self-neglect in the elderly include cognitive decline, physical limitations, mental health issues, and the fear of losing their independence. Physical abuse happens when someone causes bodily harm, for example by hitting, pushing, or slapping. Physical abuse may also include restraining an older adult against their will, such as by locking them in a room or tying them down to furniture. Warning signs for physical abuse include bruising, welts, and other wounds in various stages of healing. Inflicted bruises are usually found on the buttocks and lower back, genitals, inner thighs, face, and ears. Pressure bruises caused by the human hand may be identified by oval grab marks, pinch marks, or handprints. Human bites are typically inflicted on the upper extremities and can cause lacerations and infection. Sexual abuse in the elderly involves any non-consensual sexual contact or activity with an older adult. This type of abuse can occur in private homes, nursing facilities, or extended care settings, and is often perpetrated by caregivers, family members, or others in a position of trust. Physical signs may include bruising or bleeding in the genital area, torn clothing, or unexplained infections. Emotional signs can include fear, withdrawal, or sudden changes in behavior. We should consider injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse in any patient. Many elderly victims are unable or afraid to report the abuse. We should always take an older adult's claim of being hit or mistreated seriously, and we should transport the victim to the emergency department for care and further evaluation. We will talk about mandatory reporting requirements at the end of this session. Elder psychological abuse, also known as emotional abuse, involves inflicting mental pain, distress, or anguish on an older adult through verbal or nonverbal acts. This type of abuse can include yelling, insulting, threatening, humiliating, intimidating, or isolating the elder from friends and family. Unlike physical abuse, psychological abuse often leaves no visible injuries, making it harder to detect. Victims may appear withdrawn, fearful, anxious, or depressed, and may show sudden changes in behavior or self-esteem. Abuse can occur in homes, long-term care facilities, or other settings, and it severely impacts an elder's emotional well-being, often leading to a decline in both mental and physical health. If you suspect that your patient is a victim of psychological abuse, you should transport them to the emergency department to get them out of that situation and to get them appropriate social services and assistance. Elder or financial abuse occurs when somebody illegally or improperly uses an older adult's money, property, or assets for personal gain. This can include stealing cash or possessions, forging signatures, coercing the elder to sign financial documents, or manipulating them into giving away money or control over their finances. Often the abuser is a trusted individual such as a family member, caregiver, or financial advisor, which can make the abuse difficult to detect and even harder for the victim to report. Signs may include unexplained withdrawals, sudden changes in wills or power of attorney, unpaid bills despite adequate income, or missing valuables. Financial exploitation can leave older folks unable to afford basic needs and can cause deep emotional harm by betraying their trust and independence. EMS personnel fall under the category of healthcare professionals who are legally required to report suspected abuse, neglect, or exploitation of a vulnerable adult. This includes pediatric and geriatric victims, as well as any other individual over age 18 who has a physical or mental condition that substantially impairs their ability to care for themselves. Reports of suspected elder abuse and neglect, including patient self-neglect, should be filed with your State Department of Social Services, Adult Protective Services, within 24 hours of your contact with the patient. Many states offer a centralized number that can be called or offer an online reporting option. Additionally, in many states, your name as a reporter will remain confidential. While some cases of abuse or neglect may be unintentionally caused by frustrated or exhausted caregivers, the report should still be filed. Adult Protective Services will investigate the complaint and can provide assistance and support to caregivers in these situations. This brings us to the end of this session. For more information on today's topics, please consult your EMT textbook. Thank you for watching this video.